Welcome everybody. My name is Professor Nancy Fontaine. I'm the Chief Nurse at the Norfolk and Norwich University Foundation Trust, and I would like to welcome you to our Dementia Fair for Dementia Action Week. And today I am in the cast of some doyens, I have to say, seminal experts in all things to do with dementia care. I feel very privileged to have a panel around me who are going to try and help all of you with the questions that you've always wanted the answers to, any conundrums, any problem solving and any signposting that we can help you with. Today is about a really practical session for the here and now, and also gaining any ideas that we can do to help not just the Norfolk and Norwich carers and patients, but also our local community. So please do ask questions. But without further ado, I am going to hand over one by one to each one of my panel colleagues to say, please, could you just say a little bit about who you are and what you do? And my first panel member to come into the spotlight is Dr. Sarah Clark, who is our consultant dementia lead. Welcome, Sarah.
Hello, Nancy. Thank you for that introduction. My name is Sarah Clark. I'm one of the consultant geriatricians at the Norfolk and Norwich Hospital, and I am the clinical lead for dementia here. I work with a wonderful team in the Older People's Medicine Department, and also I work very closely with our dementia support workers and our palliative care team in the hospital as well, several of whom are here today. Thank you.
Thank you very much, Sarah. And then I'm going to go to Liz Yaxley.
Hello everyone, my name is Liz Yaxley and I'm Dementia Services Manager here in our hospitals. It's nice to have you all here. I manage the dementia support team here in the Norfolk and Norwich Hospital and also help with the strategy around improving our care and services for people with dementia.
Thank you, Liz. And now I'm going to ask Lindsay Hannant, Dementia Palliative Care Specialist Nurse, and somebody that I am so excited works at the Norfolk and Norwich. Lindsay.
Hi, thanks Nancy. So yes, my name is Lindsay and I am a dementia palliative care nurse at the Norfolk and Norwich. So yes, I work very closely with the dementia support team and I'm based within the palliative care team, supporting patients living with dementia, supporting their symptom control and end of life care needs.
Thank you very much there, Lindsay. Now, in no particular order, but in my bottom left-hand screen, I have Jenny Wargrove, our Dementia Care Specialist Nurse.
Hello, thanks Nancy. Yeah, so my name's Jenny Wargrove. I'm a Dementia Care Specialist Nurse working at the Norfolk and Norwich Hospital. So I work as part of the dementia support team. So I work closely with Lindsay as well. And my role is supporting patients living with dementia who are inpatients here at the hospital. And it could be supporting people with complex needs, such as people experiencing poor oral intake, people that are maybe distressed in the hospital, and supporting with discharge planning as well. Thank you.
Thank you very much, Jenny. And now I'm going to go to Jill Noble, our dementia support worker from the Alzheimer's Society.
Hello, good afternoon, thank you. My name is Jill Noble. I work for the Alzheimer's Society as a dementia support worker. So my role is supporting the person with dementia, the carer, the families. We work in people's homes. We deliver support over the telephone and virtually as well. Thank you.
Thank you, Jill. And then Jenny Hodge, our Admiral Nurse Team Clinical Lead. Welcome, Jenny.
Hello, everyone. Thank you, Nancy. Yes, I'm acting clinical lead for the Central Norfolk Admiral Nurse Service at the moment, and our focus is very much supporting families living at home with dementia. The focus for our service is very much around helping carers with the struggles that they face, and help with developing strategies to help them sustain caring at home with their loved one.
Thank you so much, Jenny. Now, the reason I did this, I made them all do a little sort of biography, is because just to show you the service coverage that we do have and the extent of expertise here, and it's really important because each of my panel colleagues carry some real nuggets of information that everybody needs to know. So I think that was really important. Now, there are some rules of engagement in these panel meetings. I'm still waiting for one more panel member. I don't think he's joined us yet. I'm hoping that Dr. Adrian Leddy, our clinical psychologist and mental health liaison, would have joined us. He may well still be stuck in that little corridor, but I will introduce him if he arrives. So the rules of engagement. If I could just ask that we don't share any patient level information, that would be really important, in just under the bounds of information governance and confidentiality. So please, for members of the public and indeed panel members, we do not want to share anything that we might be able to link with the patient. That's really important. So if you could just keep that broad. And I think the other thing is when people are not talking, if you could all mute yourself so we can actually improve the sound quality. I will try and field as many questions as I can. We have got some questions for people who've already sent them in. And we will help you in any way we can. I will also say if there are questions that we haven't answered today, you can always email any of us and contact us through the website if that would be helpful. So without further ado, I am going to hand over to Liz Yaxley, because I am absolutely delighted that the Norfolk and Norwich University Hospital have we have launched today our dementia strategy for the next 5 years. And this hasn't been done in secret in a dark room. This is the aggregation of staff views, expert practitioner views. This is across from stakeholders, families, carers, really important. So this is a co-produced dementia strategy for the Norfolk and Norwich University, but actually more importantly for our patients and carers for the next 5 years. Liz, over to you.
Right, thank you. What a lovely introduction. So I'm going to actually talk through a summary of our strategy. Sorry, beg your pardon. So this is a summary written for people living with dementia and their carers of what we'd like to set out and achieve over the next 5 years. So I'm going to take you through the 8 goals that you can see on the screen here and just talk through them one by one. So our first goal is around improving the skills of our workforce. We want to provide staff with the training which will enable them to provide the best person-centred care that they can in order to improve safety, patient and carer experience and the outcomes for our patients. So to achieve this, we'll ensure that our staff are trained and skilled in dementia care, and we will provide specialist services which support you and your carers. Our second goal is about working together. We'll continue to work alongside our health, social care and third sector partners to ensure the ongoing health and well-being of people with dementia and their carers. We'll recognise the benefits of working together in collaboration between the person with dementia, with staff and their carers and families in promoting safety, supporting our communication and sustaining well-being. So to achieve this, we will treat you and your carers as partners in care.
Liz, the slides aren't moving. I just thought I'd interrupt at that moment so that we can get the right slide as you're talking. Are you on slideshow?
I believe that I am, but it's obviously not working. What can you see on the screen at the minute?
A lovely title slide.
Is that all? That's a shame.
If you flicked on to the next slide there, so you might have to do it manually. So there we are. So that's now come onto our goals.
Okay, I was just trying to get rid of this down the side here, but I may have to leave that on.
Okay, you might have to just click on the slide and move through if it's.
Can you see anything moving now?
No, we're still on our goals.
Oh dear, I am sorry. Sorry, everybody.
Well, you can do it manually. That's absolutely fine.
Oh, gosh. Okay.
Talk through the goals and then manually move your slides. I think that's it. There we go.
Okay, I'm sorry you've got the this screen along the left hand side, everybody, but we'll just have to go with that. So so we were talking about, I believe, goal 2, working together. So we wanted to treat you, that's the person living with dementia, and your carers as partners in care. We want to work alongside your GP and community services and promote dementia awareness and develop our services with our local community. Our third goal is around assessments. We want to ensure that people with dementia and their carers have access to accurate assessment of their needs and that their care is delivered accordingly. And to achieve this, we'll ensure that you and your carers have a comprehensive assessment of your needs, that we'll refer you for an assessment if we think that you may have dementia, and that we will support your decision making through use of the Mental Capacity Act. Goal 4 is around person-centred care. If we're providing the best possible care, it requires us to know if you're living with dementia and to understand your individual needs, preferences and wishes. Our care plans need to be adjusted accordingly and pathways in place to facilitate seamless transitions of care. So to achieve this, we will be aware that you are living with dementia. We'll ensure that your care is person-centred and meets your individual needs, and will enable smooth transition between our services and as you're discharged home. Goal 5 is around volunteer support. Volunteers contribute to really positive patient experience by providing additional support for activities and pastoral care which complement those of paid staff. We want volunteers to have the appropriate training and support structures to help patients and carers across our hospital environment. Our 6th goal is around environments, so where people are cared for. We know that adjusting to new surroundings can be problematic for people living with dementia and can be quite challenging for people. So we aim to provide your care and environments which are comfortable and supportive and promote your safety, well-being and independence. And we're going to enable you to find your way around the hospital sites, as we know that can be quite tricky at times. Our 7th goal is around research. We know that research helps us to understand the causes of dementia, to develop effective treatments and improve care. We want to build on our existing research and develop new regional and international research collaborations so that our patients and carers have the opportunity to participate in world-class research. And our final goal, goal 8, is around governance, which we need to have in place to make everything else happen. We want to enable continuous improvements in the quality of care for people with dementia and their carers, including resources and governance structures that support staff to deliver care which is dementia friendly. So that's it. This is a very, very condensed version of our strategy, and we're really looking forward to working on all the details that need to be put in place so that we provide the best possible care and services for our community of people living with dementia and their families and carers. Thank you.
Thank you, Liz. And our aspiration is without doubt to make sure that we provide the best possible care to support our local community, our people living with dementia and those who care for them. And so although we know that we deliver great care, we want to be even better. And would I be right, Sarah and Liz and Jenny, that what we would really like is to actually join up all of the dementia care and treatment for Norfolk so that it is completely connected? That would be a future aspiration, so that it feels completely connected when you are a patient and a carer. Liz? No, it's gone to Sarah, I think, actually. I could just see you rounded a red box, actually, and I can now see, I just want to introduce someone. Before you speak, Sarah, look, I can see someone sitting right next to you who needs to be introduced as a fantastic panel member, Dr. Adrian Leddy. you have missed your opportunity right at the beginning to say who you are and what you do. Some people might not know your involvement in our team. Would you like to say, just introduce yourself?
Of course, thanks. I did manage to get on. I could see you say no, but I just couldn't interact in any way. So I've come up and shared with Sarah. Good afternoon. My name's Adrian Eddy. I'm a clinical psychologist by background. I work here at the NNN in the psychiatric liaison, in the mental health liaison service. Before that, I worked for about 10 or 12 years in older person services on the coast. So a lot of my role was in the identification and diagnosis of dementia, but also the treatment and subsequent management of difficult or distressed behaviours in dementia. And before that, I was a researcher working on some early trials for some of the cholinesterase inhibitors, which are the medications that are prescribed in NICE guidance for the use in dementia. Thank you.
Thank you very much, Adrian. And could you hand your headphones, which I hope, back to Sarah, because somebody has agreed with that comment, actually, Sarah, about Norfolk should have one approach to dementia intervention and care, because it says here creates a postcode lottery. Sarah, do you want to talk about what we're trying to do as well as to connect the strategy outside of Norfolk and Norwich?
Yes, certainly. I mean, we would all, I'm sure everyone here would agree that we need just one system really that's standardized across the county so that everyone gets the same services available to them where they live. What we're trying to do so far is Liz and I are setting up links with other hospitals, not just within Norfolk and Suffolk, but also going down into Essex and looking at what services are being given in different places and working out then perhaps a good baseline to start with, and then how we can then help develop services in other areas. And when it certainly comes to research and to joining our research activities together, yes, UEA certainly here is where we're looking to focus that side of things. But dementia research is still developing within this area.
Thank you very much, Sarah, and certainly all of the practitioners. We do want to make sure that we involve as many in research, ongoing research with UEA to further improve services. Now, there's a great question at the top, and this is going to be for you, Lindsay. It's perfectly ready for you. So we pride ourselves at the Norfolk and Norwich for delivering outstanding end-of-life care. But we can always do even more and be even better. And the part of this conversation with Liz and I and Julie Noble, who leads the end of life team, saw the rise of Lindsay's post. And there's a beautiful question here for you, Lindsay. What does good end of life care look like?
So good end of life care is a really good question, isn't it? So I believe it's a multitude of things. I don't think it's just one thing that makes up good end of life care. Importantly, making it person centered. So what is important to that person, so making sure it's individualized, and so that patient living with dementia is living well as possible at the end of their life as well. And also good communication between staff and that dying patient, involving them in decisions is really, really crucial. And as well as ensuring that the patient is comfortable managing their pain and other symptom controls, so making sure they're not just stressed in any way. And like I said, just that holistic approach, that whole person, so not just looking at one thing, and also just discussions around that patient's preferred place of care, where they want to be, what's really, really important to them as well. So I don't think it's ever one thing. I think it's a whole thing to make sure that someone's end of life care is good.
Lovely, perfect. And I think that it would probably be helpful as well, I think, because some people may not know some of the services that they can access and how that might help them, because it's very well us working in the organisation and us trying to expand the services across Norfolk, but we do work with a lot of different stakeholders. And I just wonder if at this moment, if I might be able to invite Jenny, because there will be questions more about the Admiral nurse support. Could you just say a little bit more about what you do? Because maybe not everybody knows.
Okay, so the Admiral Nurse Services is very much focusing on supporting those carers that are facing challenges, as I said at the beginning. So what we'll do is a comprehensive assessment of what somebody's needs are, whether there's any risks, and look at a wide range of every aspect of what's affecting that family at home at that time as a consequence of the challenges that the dementia diagnosis is bringing. So we'll incorporate a variety of strategies, if you like, so including education to help families understand what actually is happening and why dementia is making changes that they're seeing, looking at coping strategies, what can be done to try and adjust and change so that things feel a little bit more copable at home. And we'll also onward refer or make suggestions as to what other services might be appropriate. So that may be liaising very much with the GP, social services. We do have good links with the Alzheimer's Society, and we also link in well with the dementia support team, yourselves up at the Norfolk and Norwich. So we're all registered nurses, and we're there for when things become really quite complex and there's an adverse or detrimental impact on those that are looking after the person that may affect their ability to continue to look after them the way they want to.
Thank you, Jenny. I can't let you off the hook yet because there is obviously real interest in the Admiral Nursing Services, and North Norfolk often, for many other reasons, is often cited as a place where there are fewer services. And one of our questions here is about a family who are really struggling to get, I presume, to be able to have some access to information and support. Do we cover North Norfolk?
The current service is Central Norfolk, so that's North, South and Norwich area. Obviously there's moves towards greater coverage across the whole of Norfolk and Waveney into next year, but as yet that's still being sorted. So at the moment, North Norfolk is covered, and referrals to the service are via the GP, integrated care coordinators that sit in adult social care, the Alzheimer's Society, and yourselves can come to us directly as well.
So the GP is really important to this family, so that's a way they can. So I hope that helps you. And also, look, because we're actually working really closely with you, but it's one of the questions here is that the James Paget don't have a link with Admiral, is that right? So there aren't any Admiral nurses, but that we can still link in.
I do apologise, the signal went there, but I think what you were asking was about the James Paget not having access directly. Yeah. So unfortunately, our service for sort of home consultations, visits, or that sort of face-to-face contact isn't achievable across there as yet. However, we'll never turn anybody away on the telephone. We would invite people to make contact and have those discussions, and if we can offer support in that way, give advice or information, then we'll gladly share.
Thank you. I hope that helps, and of course we will continue to grow those links across all of our partner organisations. One of the questions that comes up quite often from family and carers, and there is a question here, and I'm going to ask Liz Yaxley for some help here. I think my partner has dementia, but she won't go and see the GP. What do you suggest?
Yes, that's a question that does come up quite frequently, actually. And for some people, it might be in the earliest stages of dementia. They might not realise there are changes. It might be other people around that person who are spotting and noticing differences. It's very difficult because obviously GPs will have a duty of confidentiality, and plus you can't make somebody go to the GP as an adult and so on. So it's very difficult. I mean, I think persuasion, obviously, if that doesn't work, then I would be tempted as a family member to contact the GP myself and let them know, maybe put it in writing and send it to the GP, because the GP will read that and they'll have that on record. And it could be when there's a next consultation about whatever it is, that information might be available to the GP. They'll have that on their record, and maybe they can bear that in mind when they're seeing the person and maybe widen the consultation around that. I think, you know, it's a very difficult one. That would be my suggestion. I don't know if anybody else has any thoughts on that.
Jill.
Yes, I agree with Liz. I think sometimes it's around making the contact yourself as a concerned family member. That will often prompt the GP to get in touch. We use that quite a lot. And the other thing is also acknowledging that the person may feel that there is something wrong, and actually by going to to get a diagnosis, it might not be dementia, it could be another illness, it could be due to medication and other reasons. So you could be ruling out other things. And for some people, they often say afterwards, I am pleased because I thought, someone said to me once, you know, I thought I was going mad, but now I know what I'm dealing with. So, yeah.
Thank you, Jill. And it does come up often, and it is a worry, but I do think that the advice there is the right thing to do. Now I'm going to move to Jenny, because this is about how we support people living with dementia and their family members during hospital admission, and then how we support them coming to outpatients and follow-ups after that.
Brilliant, thank you. So obviously I'm going to talk about the amazing dementia support team that we have here at the hospital. So we have 5 wonderful dementia support workers and myself as the nurse in the team. Because we're quite a small team for the size of the hospital, we do focus a lot of our support on older people's medicine wards, but we do also triage referrals from elsewhere. So we will accept other people on different wards that do really need our input. So that support is really tailored to the person. So we'll, in the first instance, we'll obviously meet the person, get to know them, hopefully complete a This Is Me booklet, if people are familiar with those by the Alzheimer's Society. This this helps us to support the person by knowing their kind of likes, dislikes, food preferences, things like that, even about their mobility, their hearing, things like that. And we'll use that to support them while they're here in hospital. And if we can, then we'll link up with the carer or the relative and offer them carer support as well, if that's something that they would like. But like I say, it's very tailored to the person, because everyone living with dementia is so different. So we're really very person-centered in our approach with that. And if I need to get involved from a nursing perspective, as I was saying at the beginning, it might be things like someone with reduced oral intake. So I'll be looking into reasons why that might be happening, and particularly if someone's really distressed in hospital as well, because obviously an unfamiliar environment for people. So we really want to support them so they're as comfortable as they can be while they're here in hospital with us. And going forward to kind of support afterwards, we do a lot of support around discharge as well, helping the person to maybe look at photographs of a new care setting they might be going to, and being that kind of link between care settings, so we can hand over information about the person that might be really helpful for them to know. And we do refer on to the other services that are here today, like the Admiral Nurses and the Alzheimer's Society, so the support continues into the community. In regards to outpatients, we currently don't have an outpatient support from our team, but we do have a new exciting role that's starting in June, which is Macmillan Dementia Support Worker, who will be supporting outpatients coming in for cancer treatments. So watch this space with that one. Hopefully they'll be starting soon, and they'll be referred to in the same way they're referred to through the team. So that's very exciting.
It is really exciting, and there's a request here. Could we have a NNUH design and information booklet for services available with telephone numbers, so that we can give it to the wards and so that then they can give it to patients and families? Is that something that we could do, or do we have that? That's for you, Jenny.
Yeah, I was going to. It's definitely something that we're doing. I know there's some little bits exist, but nothing official. I know that Liz was we were developing some ideas for this, so Liz might be able to answer that better than I can.
Certainly something we could look at, and we would also want to have carer input into co-producing that. And then of course we discharge people often into care homes. So, and there's about support to the care home after discharge. So can anyone want to explain how we work with the care homes? Is that something that Jill or Jenny could look at outside of the Norfolk and Norwich?
Hi. Yeah, we often will support someone in that transitional period, and the referral will come through from the discharge team that someone is moving. Very often, I would say that we have that ongoing relationship. So we are supporting someone who has gone into hospital, and then the circumstances have changed, and they're moving on to care. And it is about supporting at that point, probably the carer, to understand the changes. At the moment, it's been quite difficult, obviously, because that transition has been made solely by the person with dementia, and there's no visiting or settling in period with the family. That has proved to be a challenge. So we're there for the carer, we listen and we acknowledge their concerns, and then enable them to think about what they can do to help the person settle in the home. And again, as Jenny touched on, we use the "This Is Me." We encourage either it goes with them or they start a new one. So we support the family in completing the "This Is Me" and provide that ongoing support as long as the carer needs it.
Thank you, Jill. And there's a big showcase and a big round of applause there. Jenny, your team have got a big, and I'm presuming now you see it could be Jenny or Jenny. So I'm going to say it's both of you. Both take the compliment. Look at that. That's lovely from Tim. I just want to go back, actually, Adrian. This is a really good question. What happens if a patient attends the hospital and displays memory or cognitive problems and doesn't have a diagnosis of dementia? Is there a process to test within the hospital, or would they be referred back to their GP?
So generally the process is we would rather not make a diagnosis of dementia in the hospital. And there's a number of reasons for that, and really the crux of it, the main reason is when people are in hospital, they're going to be very unwell and we'll see lots of symptoms of other things. So delirium is really common, and delirium will often kind of come and it will go, but it will mask the symptoms of dementia. So the danger is actually if we try and make a diagnosis in the hospital, it's quite easy to get it wrong. It can diagnostically overshadow other things. So we have to be a degree of kind of being cautious about that. There are what I would describe as exceptional circumstances, like once in a blue moon that we have made a diagnosis in the hospital, but that is really rare, and that's something that really as clinicians we wouldn't support, because I think there are more risks than benefits from making the diagnosis at that point. But it's a really good question, because actually someone kind of might come into hospital and there might be some emerging cognitive impairment, and the family might say, well, actually this isn't new, this isn't something that we've seen since they've come into hospital. We've noticed this change for maybe 4 or 5 months. We might start to think, well, okay, 4 or 5 months, this is starting to meet some of the criteria for dementia. It might be something that we want to look at further. So the process we have, instead of sending back to the GP, is we have a service called Memory Matters, which sits in the community. So Memory Matters is a community service run through NSFT for assessment of people who might have dementia. So the wards can directly refer someone over the age of 75 to Memory Matters, so that they will be followed up. So they're kind of earmarked as someone that we think needs to be investigated further, provided they consent to having that referral. The wards can make that referral on very straightforwardly. If someone's under the age of 75, there is still a pathway. So the pathway might be they come through mental health liaison service, and we kind of have a look. We think, okay, this does seem a bit unusual. These changes that someone's reporting seem a bit beyond what we might typically expect, and we'd like to have this looked at further. We would try and directly refer them into the community memory treatment service. So there are 2 pathways there, and they would tend to be easier pathways than going back to the GP, because otherwise you kind of the GP then refers the person into the memory treatment service. So yes, there are kind of pathways there, but we would try wherever possible to avoid making the diagnosis in hospitals, because there are more risks than benefits.
Adrian, thank you. And there is a really good question, because not all of our dementia patients do have anyone that they live with. They are on their own. You know, how do they get support if they don't have any local family and they've got their diagnosis, but how would we make sure that we connect them with other services?
So I would hope in the part of the diagnostic process, there should be a series of things done. So the first thing we should do is pre-diagnostic counseling, and that is explaining to the person what we're assessing for, and we're letting them know up front that, you know, we're looking for a variety of things that could explain these symptoms. And one of those things that this assessment might come out of that is it might be result in a diagnosis of dementia. It might be lots of other things, and that will have various consequences for life. So, for example, you have to report that to the DVLA, and it could have an impact there. So the first thing we do is we support the people in letting them know what they're signing up to. That the assessment then takes place, and that contains a variety of interviews, maybe scans, maybe neuropsychological assessment, blood tests to rule out other things. And after that, when we have a clear answer, we feel it might be as probable dementia, we'll do post-diagnostic counselling. And part of the post-diagnostic counselling is absolutely those things that you're talking about, Nancy. So this is what happens now. This is the diagnosis that we think that this is most likely. Like, we can never diagnose dementia 100% unless by autopsy or biopsy. So we can never be 100% certain, but this is what we feel it's most likely to be. Given this, these are the options that are available to you and things that we have available to support. So some of that will be based on the type of dementia. So, for example, the cholinesterase inhibitors, which are the drugs we use for dementia, are licensed in two types, Alzheimer's and dementia with Lewy bodies. But those drugs don't work in things like vascular dementia. So we would think about what the recommendations are for the subtype of dementia, and we would try and follow through with those. But then there might be kind of wider support things that are available to the person regardless of the diagnosis of dementia. There might be third sector organisations that support. There might be things that we can offer in the NHS. So if someone's kind of isolated, there might be things that we think are quite important that we can refer them on to. And that's at that point it should take place. And each person will be unique, it'll be bespoke based on their presentation, their life circumstances.
Thank you, a highly comprehensive answer there. And I'm going to swing it over a little bit to Liz, because obviously not everyone has come into hospital yet since they've had their diagnosis of dementia. And there's a question there about if and when I do come in, what's going to happen to me? And actually there's a further one there saying about is there a passport like our learning disability patients have? So I thought you'd like to talk about what we do when somebody comes into hospital with the This Is Me tool and about the support with the carers.
Yes, of course. So if we know somebody is living with dementia, we will see if they have a This Is Me booklet, which is, I think somebody had mentioned in the chat about a learning disability passport. So it's kind of the equivalent, if you like. So it's a person-held document. It's sort of a trifold leaflet, and within that it tells you all the information that the person wants us to know about them, very personal information about how the person likes to communicate, maybe food and drink preferences, things about how they might like to take their tablets, right through to details about routines and background that's important for us to know about them. So we check to see if somebody already has one, and if they haven't, we either the ward staff or our dementia support team, and we've actually got a team of volunteers working on this now who are reaching out to people with dementia and their families and saying, please, could you help us fill this in, because it helps the whole team caring for the person to know about those individual needs and preferences. So then we have that by the person's bed so that anybody can access that who is caring for the person. That really, really is incredibly helpful. So we're always on a campaign about promoting awareness of This Is Me, and if there's anybody living out there in the community who hasn't got a This Is Me already, please get one. I'll happily send you one in the post. It's a really good thing to have with you at all times, because you never know when you might come into hospital or go to the dentist or go anywhere where you want to communicate that. It helps if you come for an outpatient appointment and so on. So that's what we do regarding This Is Me. It's absolutely really important for all of us to have that information if you find it difficult to communicate that yourself. Regarding people's care as well, we have a variety of support services available to us. So in terms of this, you know, obviously we have people on the ward who would be happy to support you as a carer. We have our dementia support team who will reach out to people's carers, and our mental health liaison team will also do that as part of their work. And we have the agencies that we refer on to afterwards for additional support in the community. So the Alzheimer's Society, the Admiral nurses, and so on. But in terms of us sort of reaching out to carers, if you want and if you are able to carry on your caring role while the person that you care for is in hospital, if you want to come in and share that care, we will welcome you with open arms. We have a carer's passport. It isn't just for people who care for people with dementia, it's for all adult carers of adults in our hospital. And we invite you to, it's a nice way of saying to you, thank you for coming in to share the care, and it gives you sort of a meal voucher which sort of entitles you to reduce meal prices in our canteen facilities, and it gives you free parking as well, and a little bit of information that might help too. So it could be that you want to have flexible visiting, so you want to be able to come in and out or stay with the person that you care for long periods of time or overnight. If we can facilitate that, we will. And it could be that for certain parts of the day you feel it's important to come in and share the care with us. So that might be at times, it might be helping the person to get to sleep at night. It might be helping at meal times. So please, we would welcome you to do that. Is that enough?
Yeah, that's perfect.
Okay.
And I'm going to be, I am presuming that all of the services then use that This Is Me tool both in and outside the organisation, whether it's Jenny's team or from the Alzheimer's Society. And Lindsay, you would also as well, when you get asked to come and work with the family and the patient, you would also draw upon the information in the This Is Me, just showing that how coordinated it is across the team.
Yeah, absolutely. As I said at the start, I do work alongside the team. So coming to see a patient who perhaps can't communicate their needs or their wishes is a really good information source for me to be able to know a little bit about that patient, and it enables me to engage with that patient a little bit more. So if you know a specific, bit of information about a patient, and you can use that within my assessment process to make it person-centered and individualized to that specific patient. So yeah, it's absolutely crucial to know that little bit of information that's important to that patient within the trust.
Thank you very much, Lindsay. And Sarah, Dr. Sarah Clark, often challenging behaviours are something that families, carers and staff that find very difficult to manage. And there is a comment there. I've had experience with those who display challenging behaviours being labelled as aggressive by staff and then having security with them, who I'm assuming are not dementia trained. And, do you want to talk a little bit about how all of the training we are doing in the organisation? And then I suspect Jenny W will want to come in as well, because we're doing a lot of work with all of our staff, aren't we, on dementia training? I can't hear you, Sarah.
Sorry, can you hear me all right now?
Yes.
Good. I think we would all agree how frustrating some of the negative terms people use to describe behaviour can be, and how that then impacts on how other members of staff can view the patient, and then it can affect their stay in the hospital. And we do appreciate that, and we recognise it on the wards every day. And we're trying to change that sort of attitude and move away to perhaps better descriptions of behaviour that have less negative connotations with them. I think with regards to the first part of your question was about how we manage the patients, I think, on the wards who do get distressed. And I think it's a variety of things, really. Initially, it's a lot is trying to do what Jenny's been talking about, and Lindsay with the This Is Me, and trying to work out what triggers someone might have that makes them distressed, and trying to think of ways to communicate with that patient to try to make them less agitated and less upset with us, and then working out what we've done within the hospital to make the situation worse for them, and what medical or nursing needs they might have, to try to improve their symptoms and make them feel better if they're unable to communicate their exact symptoms to us. So that's actually quite a lengthy process that we do go through with all of our patients on the wards. And if we need help from the mental health team, then our colleagues Adrian and the other people he work with also can come and help us, and they have some background from the community teams as well, which they can give us for each patient as well. So it's a sort of a mixture of everyone working together. With regards to education and continuously updating the education within the workforce, it's a large job. I don't know exactly how many employees there are in the trust, but it's a very large number, and pretty much people with dementia come into every area of the hospital, apart from probably the paediatric wards. They're pretty much, they come into every other service. So it's about trying to make sure that whatever teaching and education programs we run can be accessed by any member of staff and are accessible to people with different training and different experience themselves. There are general dementia training programs within the electronic sort of teaching programs that we have. We are working to try to develop a series of lectures to try to help develop staff training through that way. And I think Jenny may want to, or Liz may want to come in to talk about how we're looking at some virtual reality type training to particularly help with patients who can get upset, and how the staff can then respond to them to try to diffuse the situation rather than things escalating up to security, which is the last thing that any of us would want to happen, including security, I think, to be honest. So trying to work that way, but it is a huge task, which we are working on. I don't know if that answers all the question.
No, it does. I'm going to move to Jenny W, just to talk a little bit about how your work in training and educating staff. And also, there's a question I'd just like you to answer about how all the wards are clearly indicating patients with the diagnosis of dementia, because this is all very much what you do on a daily basis, and I think that would bring some reassurance.
Yeah, absolutely. Thank you. So I'm really glad this question came up, because it's something that we see a lot, actually. And so we do all new healthcare assistants in the hospital will have a Dementia Friends session. So this is an information session actually created by the Alzheimer's Society to try and create dementia awareness and communities that are more understanding of people living with dementia. And it covers things like terminology of words of when we're talking about people living with dementia, what words we use, avoiding words such as like aggressive when we're describing people, and trying to focus on what the person's trying to communicate and their emotions behind what's happening, and things like that. And I do think that the staff find that really, really helpful. We also talk through scenarios of situations like this where someone might get quite distressed on the ward, and how we would support them. So as we were saying before about using the This Is Me booklets to help understand the person and tailor the care that they're receiving here, and try to preempt any causes of distress. If we know that something in particular will distress somebody, then knowing that is really helpful, because we can try and stop that from happening. And the second part of the question was about the ID scheme that we have here in the hospital. So we have a blue forget-me-not flower that goes behind the person's bed space, and we also have a blue wristband for the person to wear as well. So they are really helpful when identifying people that are living with dementia. And in answer to the question, obviously anyone we're seeing, we would make sure that's in place if the person consents to that. If they can't consent to it, we do it in the person's best interest, obviously. And yes, we audit that monthly. So we do go around the wards and encourage that that's being used, and make sure it's being used in the appropriate places for any people that have a confirmed diagnosis of dementia, not people that are experiencing acute confusion like delirium or something like that. but it is something that we actively promote, and I think it's you know, it's getting better. I think the use of it is really helpful, and the staff are definitely picking up on that. I hope that answers the question. I don't know if anyone wants to add anything to that.
Liz, did you want to say anything about virtual reality and part of the programme of work? If it isn't you, it might be Sarah, because I just saw Sarah's hand go up. No.
I'm delighted to tell you about this virtual reality programme because it's so innovative. I can't take any credit for the idea, but what I'm doing is working with a team of people. We've gone out to lots of consultation of our staff, our dementia links, our dementia strategy group, to think about how we can make virtual reality really help our staff who to understand what it might be like from the viewpoint of a person living with dementia. And we've looked at 4 particular aspects of the care experience. We're going to make these very exciting films. We're in script writing stage at the minute. So what will happen is you will probably be working in small groups. You'll put on your virtual reality goggles, and what you will see is from the experience of the person, of the patient living with dementia. We're going to try and make this as realistic as we possibly can. And we're going to have 4 different scenarios. One is about helping the person at meal times to eat and drink. One is about our communication skills. One is about facilitating and helping people to orient with orientation around their environment, and the other is about helping people through procedures like taking blood pressure and so on. So these are 4 common sort of scenarios that in the hospital that might be great learning points for our staff. So we'll work in small groups. Everybody will experience certain scenarios around those 4 areas, and then it's great for them to have a sort of teaching session around that, thinking, what was that experience like? What was it that the staff did that you found very beneficial in these clips? What did you find less helpful? And then helping people to think about their practice. So it's really, we're really looking forward to doing that and working on it.
Thank you, Liz. Always innovative at the Norfolk and Norwich. And I'm going to invite Adrian to talk about some ongoing research and new avenues of research that I know that he's very keen to share, because that's how we learn and improve our treatments and interventions.
So I suppose there's a lot of research is kind of always going on in dementia. Actually, it's really hard just to keep track on what's happening. So every month, on average, about 750 new papers are put in peer-reviewed journals regarding Alzheimer's. So it's actually really difficult to keep up with the developments. I suppose probably the key things, I guess, that have taken place in the last few months. And there's lots of different areas of research. Some can be about recognition, diagnosing dementia. Some can be about treatments. Some can be about the psychosocial factors. It's probably one of the more important things I think I personally read in the last year was a study published 2 months ago, which looked at data of 62 million people in America. And what they noticed is people with dementia was twice as likely to experience and die from COVID. And that was even when you took into account people's age. So you took out age as a factor, you took out underlying health conditions like diabetes. And actually, one of the things we think that might be for, we don't actually know why that is, but I think the conclusion the researchers felt is probably it's something related to people with memory deficits forgetting advice and guidance, so maybe not wearing masks or washing hands or socially distancing. So actually one of the important things that's coming out of that research is actually how we can make adaptations for people to be more aware of using masks, distancing, and other good practice. So there's lots of kind of really interesting things that are happening. Maybe some of the things kind of locally that are happening here in Norwich. So on the research park, there's Professor Michael Hornberger, who's been doing some really interesting research around spatial memory. So one of the things we've thought about for many years when you think about Alzheimer's is often people think the first signs of Alzheimer's is forgetfulness, forgetting conversation. But some of the really interesting research Michael has done has shown that actually it's spatial memory is the first thing that tends to be impaired. So people getting lost, maybe getting lost in a supermarket car park. And he designed this app that was downloaded to phones to track spatial memory. And he has over about 3 million people downloaded this app across about 180 countries in the world. He's managed to get about 10,000 years worth of data it would have taken to collect in a clinic. That's shown us some really interesting innovations about actually how spatial memory is a really important indicator for the earlier signs of Alzheimer's. I guess also he had also mentioned some of the psychosocial based research. So Professor Miyoshi, who's also based in health sciences at UEA, does lots of really interesting research around carers, particularly of frontotemporal dementia. So frontotemporal dementia is a rare dementia, and often there are a lot more distressed or behaviours that people find challenging, and it'd be very burdensome for carers. And she's been doing lots of really interesting research around supporting carers and actually what works in formats, what works in a group format, what doesn't work well. So there's just lots of, I guess, kind of really interesting things happening globally. But just to give you a flavour of some of the things that we're involved with a bit more locally in the hospital and the university.
Thank you. Thank you. Can you swap? I'm going to move to Sarah now, because it's easier to keep you both in the, because actually there's a couple of really good questions, and one really, Sarah, is about the impact with patients and carers, patients with dementia and their carers this last year with the COVID pandemic. Just sharing some of the impacts that you've seen.
Yeah, I think what we've seen on the wards and directly with our patients, speaking first for patients, I think, and then perhaps speak about carers after. I think the patients that we've had on the wards who with dementia have struggled more perhaps in the last year, not having their relatives in as much as they were beforehand. We have noticed also because we didn't have as many volunteers on the ward during the same time, but helping the nursing staff with the other things that they did previously as well. So with the lack of those two groups has certainly seen patients with dementia perhaps not getting as much support as they would do normally, and therefore we've been putting more requests into our dementia support workers, to Jenny and her team, to help us more on the wards. And I think sadly, yes, this patient group has suffered. They have perhaps been lonelier. They have been more upset without those things that normally ground them when they come into a dissimilar environment. And equally for their carers, the things that we've been fed back is getting through on the phone firstly to manage to talk to someone, which obviously we've been trying our best on the wards, but when we're trying to see the patients as well, it's difficult to always be able to answer the phones for both nurses, doctors and reception staff. And so I think there's that frustration from the carers' side, that they want to be with the person that they care about, and when they can't get response from us at a timely manner. And so I think that's led to some dissatisfaction with the service that we've been able to provide. And all I think any of us can say is that we're sorry, and that we've tried our very best during this last year. I think everyone has, in every area within the hospital, to try to ensure that every patient has the best support that we've been able to give on the ground. I'm sorry, I don't know.
No, I think that was a really honest and refreshing. I know that our listeners would have found that important that we were so frank, and I think that's what we stand for here. I'm going to move over to Lindsay, because there's been a comment, and it might be from the same person, about whether we have a view about patients who are end of life and often get referred to social care for support rather than completing CHC fast track. And I just wonder if you could talk a little bit about that, and is that about, is there some confusion, and could you put some clarity for the person that's asked this?
I guess it's quite a difficult question to answer without obviously having the discharge team involved, but certainly with our patients we do get involved in quite a lot of complex discharges, so we would often involve the integrated discharge team with these. So often or not they will then seek that package of care or whatever the patient is requiring for discharge. So often or not, our patients will often go home on what we call a fast track discharge. So this is what we aim to be a rapid discharge, so they can be supported at home. So it would just depend on what the patient's needs are. I'm not sure if I really answered the question. It's quite difficult to answer because obviously we facilitate and support discharges, but don't necessarily get too involved with what goes on with the social services part of thing. You know, we will obviously make sure a patient is well supported from our point of view before being discharged, and that's what we always ensuring that they would be sent home with things like anticipating medications, drug charts and numbers, so they could seek help in the community if they were to, and obviously letting GPs know that these patients were needing extra support as well. So I'm not sure if that helps, but if anyone else can.
I think that you've explained the process. Oh, is that Sarah saying yes or no? No, that's Sarah saying yes. Sarah's going to come in. She's got a comment.
Sorry, so this, just to clarify, this is the question about funding for end of life care. Is that right? What should be happening on the wards is when we're trying to organise a palliative discharge from the MDT, so from the medical doctor, physio, OT side on the ward, is that we should all be having a discussion about where best the patient can be looked after within their needs that they have, and then having talked to the patient and their relative, if they or next of kin if they have them, as to where those needs can best be met, and then dependent on those discussions and on what someone's needs are at that precise time, then depends on you have to sort of say whether someone's rapidly deteriorating, and if they have rapidly deteriorated in the time, then that should automatically go down the fast track funding, and it should all be funded. So it's, however, if you think that someone is stable, they may be in the terminal stage of their lives, but not necessarily the final few weeks, then that may well go down the side where it has to be partially funded by the individual. It's difficult, and the specifics change in the last 2 years. They have changed and they keep moving goalposts around, but it is ultimately a discussion. And so if that is you or your loved one and you have questions about it on the ward, then you should be talking, or please do bring it up with the medical team or the nursing team, so that we can explain the situation as it is at that time, if that makes sense.
Thank you. I think that brings a bit of clarity. Of course, a lot of what we talk about is in our older people and older people's medicine, but actually we do have a cohort of patients who are diagnosed much younger. So Jenny Hodge, I just wondered, you know, the support that we give for the younger patients and their partners and carers, because it may feel a little bit alien and a bit isolated because they are younger than the many of the other dementia patients. Could you talk a little bit about that?
Yes, certainly it brings forward a whole new set of challenges for the younger families that are experiencing this at home, purely from the fact that often the age group that the person is still working, so there's implications around what happens in the workplace, whether the person is enabled to continue working, and the impact that if they can't work, what that might have on financial implications and commitments that they've got at home. And of course then there may be children, and so it's about how children in the family actually understand what's happening with their parent. Or I mean, obviously even with the older age group, there may be younger children that are experiencing this through grandparents, but sticking with the younger onset, there is a range of support that's out there. Obviously, as an Admiral nurse working at that specialist level, then we will support and guide and do our best to ascertain services that are more bespoke for the needs. It's quite difficult across Norfolk, especially if there is a need to relinquish care at any time, because traditionally, if you're relinquishing care, then it will be in a more traditional older age setting. So looking at those needs, but also peer support, really important. So looking at support groups that are available. Admiral nurses are sort of behind us is Dementia UK, the charity, and we have a lot of resources, and there are younger onset sort of support groups that are available, which cover a wider range. So now we're using these virtual platforms a lot more, then there's a lot of support available there. And also that would come under the rare dementia. So a lot of younger onset families are supported through the rare dementia support groups, again facilitated through the UEA. There are support groups that meet regularly for that peer level. At the Alzheimer's Society, obviously they do the younger onset groups as well, so mustn't forget them. So I think we all work together as best as we can to help manage those particular challenges that are faced at that time.
Thank you, Jenny, and I know that many people have found that really important information there, because it's less talked about, isn't it, in some ways, and we do need to make sure that we cover all of the patient groups and across all the ages. Liz, there's a really good question about development of volunteers, and obviously we've worked really hard to bring in our butterfly volunteers at end of life. But actually, dementia volunteers are something that we've wanted to really grow, and we have a strong volunteer presence in the organisation. Could you just talk a little bit about our strategy for the development of volunteers working on the wards and perhaps in outpatients, as we've said earlier?
Yes, of course, there's a real benefit to growing our volunteer, you can't say workforce, our volunteer gang, if you like, who are able and willing and have got loads of energy and want to support our people living with dementia who are in our care. So at the minute, what we offer is, you've talked about the butterfly volunteers, Nancy, so they support people across the hospital who may not otherwise have any family or friends who can support them towards the end of their life. But we also have a group of This Is Me volunteers, so they've been specially trained and supported to be able to carry out This Is Me, completion of This Is Me over the telephone with people's families and carers, which of course really helps our wards to have that information so they can provide the best possible care that they can. So we're growing that team. So we have a great volunteer coordinator. Well, we have a number of them in the hospital, but we've got one specially who looks after all things dementia, and he is growing that team of volunteers, the This Is Me volunteers. We've also got our volunteers coming back into the hospital again, who are supporting people on the wards, working closely with the ward team, but supported by the dementia support team. So they're providing additional companionship visits and things that we know through our own experience are helping that individual person. So they're offering more of what we know is really helpful to them. And going forward, as part of our strategy, we'll be looking at lots of different ways that volunteers can offer support, including supporting people visiting outpatients. Any ideas welcome, by the way.
And that is certainly an area we can continue to grow. And I think Debbie Alden, thank you so much for your wonderful compliments. And I think also working with our volunteers as well as ward staff and growing our Forget-Me-Not, I think that would really help. And we talked about the wristbands earlier. So, but thank you so much for your compliments. And I just wanted to also pick up, now I think this might be Sarah, about medical opinions slowing the progression of dementia if people diagnosed interact more with other people socially. engaging in activities in group settings. I think it's really a question, how is this kind of support beneficial for family members, carers, if you know anything about that?
Hello, Nancy. I'll start to answer it, but I actually think Adrian's also got some answers for this as well. I mean, yes, we know that social isolation is a big risk factor for developing dementia and for dementia progressing perhaps more rapidly. So I think anything that sort of gets people engaged and doing things with other people is going to help. It may not necessarily slow the disease progression down, but it may hopefully improve the person's quality of life and therefore perhaps improve their mood and therefore improve their perception of their memory and their engagement, because they feel more able to engage. And then shall I hand over to Adrian to answer the other bit? Is that okay?
The bit of research I'm kind of most aware of in terms of those things, it's about actually learning a new skill, and it seems to be, the evidence seems to be, if you learn a new skill every between 5 and 7 years, actually that's quite a protective factor. And actually, if you can try and do those things early, kind of diagnosis of dementia, that there might be some evidence that might slow down decline. So it's not like you I guess retire and decide to learn French, or you just learn to play the guitar and just do that. The evidence seems to be that actually if you're learning something new every few years, it tends to build more cognitive reserve. There's also a bit of evidence that I'm not suggesting that we all work longer years and postpone our retirement, but there is some evidence that so it's something like kind of for every year extra you work, it might delay onset by a month or something, but I'm not advocating that that's but there certainly is some evidence around the activity level, and I think the old saying in kind of neurobiology is neurons that are fired together wire together. So there's something about actually use it or lose it, and there does seem to be something born out of the research that reflects that. So yeah, being active around people, physical activity, are all very good evidence for those things. So I think we'd all be quite supportive of those.
Well, I think you've just convinced me you won't be allowed to retire now, Adrian, so you will have to stay here with us. So thank you for sharing that research. I'm going to take a couple of questions that have already come in, because we do get asked this. So where perhaps a patient and their spouse or carer want to then relocate nearer their family member. So someone, you know, perhaps their family live in Oxfordshire, and obviously they've been having their services here. Who would be best to answer, to really give a sort of step-by-step guide about how that would happen and how they would then be mapped into the Oxfordshire services? Anyone willing to take that one? I'm looking at all of you, looking at anyone who's going to nod at me. Is that a Jill one? Jill? Jill, go for it. Thank you.
I'm clearly not medically trained, so I'll pass over in a little while. But I think one of the things is about the planning of that trip or that change, and with someone with a diagnosis, I think sooner rather than later, because you know, you can then start to familiarise that person with their new surroundings, which is always helpful, and talking about it in small pieces and small modules, if you like, around what's going to happen, and without overcomplicating the process, which clearly is a complicated process. I can speak from our perspective, it would be a transference. We could transfer you into our Alzheimer's support network, which is wherever that would be, and that should be seamless, and you should pick up a similar level of support, advice and information from that area. And I think small pieces of information, yeah, and make the move sooner rather than later. I think if you can get help from your family or friends, and if you're talking about the physical move, again, you can get support around transport if you're doing it on your own. There's lots of agencies we can refer you to who will support you in that journey.
Thank you. A lot of people have found that really useful, because I didn't know about the transport. Jenny Hodge, and would that then, if once they registered with a GP in the new area, could they then ask for Admiral link in that new area? Is that how that would work?
To the best of my knowledge, that would be the process, but of course each service is set up in its own particular way. It's whatever the area's clinical commissioning group have decided to set that up in whichever way it is, if that makes sense. So if the process there is very much via GP, and I would suggest that would be the first start. Unfortunately, there isn't Admiral nursing absolutely everywhere across the UK. So it would be a case of finding out whether there is that support available initially, and the GP may be the first port of call, but equally if there are increasing needs, depending on what stage the move is, then a social worker would hopefully have that information as well if they're involved in transferring care packages and that kind of thing.
And then Jenny, do Admiral get involved in where the carer may need respite? Is that normally done? So if the Admiral team are involved and it's very obvious that the family might need some respite, is that something that Admiral team would help with?
So we're not directly responsible to actually put in place respite services, but we would be there to coordinate. So a lot of what the Admiral nurse does is that sort of holistic assessment and then establishing what the needs are. And if respite is part of that, if there isn't a social worker already involved, then that would be something that we would coordinate. So we put on those, pass on those referrals and indicate the reasons behind that and facilitate and advocate. So a lot of what we do is advocation. So yeah, we're not directly there to provide it, but we would certainly be there to facilitate it.
And I think Jill will probably say the same thing about sort of networking and supporting and trying to link people in if the carer or the spouse needed that level of support.
Yeah.
Yes. And what about a long and also not just respite, I suppose, longer term care? So when things were starting to deteriorate, Jill, is that when you would really try and influence that support and try and negotiate that with the GP and social care?
Yes, I think similar to Jenny, we are often advocates on behalf of people, because when they're in the depths of stressful situations, you know, making a call through to get a needs assessment or a carers assessment can be quite tricksy, the process to go through. So we will often be their voice and request those assessments happen if that's what's needed. We can also provide information on what is available locally around our experience of care providers, which is often helpful as well.
Thank you. And the reason I sort of started to bring that in, because there is a question about the link with social care and hospitals. Liz Yaxley, did you want to pick up that about the joint work we do with social care, particularly when we may need to broker perhaps a different facility for people following discharge, or when things have got a little bit difficult with behaviour?
Yes, I think it all really boils down to what are the needs of the person at the time, and really trying to convey what the person is able to do, what might be difficult for them, and what their care needs are. And in order to do that, to have the best conversations about where that person's needs might be met most appropriately, it's important to get to know that person very, very well. So this is the benefit of us all working together in the hospital. If perhaps the person might be known to the Alzheimer's Society or to the Admiral nurses, for instance, or to our colleagues in the Mental Health Trust already, we'll pool all that information together, but we'll also get to know the person while they're here, and that's often pulling together again the information from the nurses caring for the person, the doctors caring for the person, and the views of the dementia support team who might be involved, really sort of looking at, you know, what does the person respond well to, particularly if there are concerns about how the person may become upset, distressed, frustrated, and that might be seen as a challenge to the person who might be going on to care for that person. We'll try and find out actually what are the triggers to that, what might make the person feel and act in a different way, so that we're trying to maximise the best information about that person, and it really helps facilitate the care going forward. We want, Sarah Clark and other people mentioned earlier about the idea about people being labelled in a way that it can be quite negative to their future care. So if we use words like aggressive, it actually doesn't really explain anything at all. So what we're trying to do is explain the behaviour that somebody might be showing at a particular time, and that we might connect things. So it might be that we understand that Mr. Brown becomes upset when there's a lot of noise going on, but we know what helps Mr. Brown is if we can help him to be in a quieter space, or if we do the things that he enjoys doing and keeping the routines that he likes. And what we've noticed is that he likes a newspaper at 10 o'clock in the morning, and he likes to have a cup of tea, and all the finer details about what might make the difference to that individual person. And in pulling all of that together, and about the medical needs and the care needs of the person, we then are in a better position to talk to our colleagues either in social services or our complex discharge team, who facilitate the next place that the person might be going to, as well as going back home and looking at any care needs that the person has in order to do that. So it's about collating the right information in order to get the right care pathway going forward. And people with dementia, their families, and any future care provider really appreciate that information, because it helps that transition to be as smooth as possible.
Thank you, Liz. And we've just got 5 minutes left, so I'm going to just give you literally 30 seconds just to give a final message or word of advice to our listeners today. So fingers on the buzzers and have a think. I am going to start with Lindsay.
So some of you may be aware that obviously my role as a dementia palliative care nurse is totally brand new, and obviously it didn't really look, we didn't really know what it was going to look like, and obviously with the pandemic. But through that time I've learned so much, and I'm really hoping to use my experience that I've gained working with the teams within the trust and the nursing teams to really be able to develop my post to ensure and develop great end-of-life care, symptom control care for patients living with dementia.
Fantastic. I'm going to drop down to Jenny Hodge.
Okay, so I guess it's that all of our services in the community are moving forward, and there is a vision for much more improved support networks out there. So we're all continuing to collaborate and work together, as was said earlier on at the start of the fair. But if you're not sure, then ask. There's a lot of services that are out there, and until you're actually facing that need, unless you ask, you may not be aware that they're already a service that's available, and we'll always do what we can to support that.
Thank you, Jenny. Jill.
Thank you. Don't worry at home on your own, whether you're waiting for a diagnosis, whether you are a carer who is about to be in crisis, or you are living on your own with dementia, get in touch. There are lots of people out there to help you. We're there 5 days a week. We cover the whole of Norfolk, and you will get the help that you need. So please don't sit at home and worry. We can help you. Any one of us can help you.
Great words. Thank you. Sarah and then Adrian.
Hello. I think mine perhaps looking more at the last year during the pandemic, and perhaps looking more like Lindsay at the end of life, so the final stage of dementia. And I think perhaps it's just something I think that we've all noticed in the last year is how important advanced care planning is. And although I appreciate that lots of people don't want to think about the end of life and what they would want, at the same time, it is good to start having those conversations with your families, or even just thinking about yourself and what you would want as life progresses, so that when things do change, that we've all got an awareness of how we can best look after you and try and make sure that we're doing what you would want us to do as things develop.
Wise, very practical, and actually quite a difficult subject for many to consider. Dr. Leddy.
I forgot what I was going to say. So I think I was going to say something along the lines of probably all of us on this call, facilitating and listening, have probably had dementia touch our lives in some way. We will have probably known someone close to us who lives with dementia, who has lived with dementia. So I guess my first reflection is dementia is kind of everywhere, and we've got much better at talking about it and thinking about it. And certainly when I reflect back to how things were at the start of my career, I think they're a lot better. So for example, we're talking about managing distress and challenging behaviour. Well, 15 years ago, one of the things we did, we would just prescribe lots of antipsychotics to people with dementia. We would pump them full of them just to essentially kind of calm them down. And actually, me and Sarah were just reflecting, actually things are lots better now. So we recognise there's still a long way to go. So I guess the final bit I would kind of leave people to think about is probably the thing that my patients that I've worked with have taught me the most is that actually, and challenge my own stereotypes and prejudices that I probably had before working with dementia, is actually getting a diagnosis of dementia isn't the end of your life if you choose for it not to be. That actually there's many ways in which you can live with dementia and live a really enriched and personally meaningful life. And that's a message I've just learned from a handful of people that I've worked with, have really taught me that. So I would leave that as just a message to take home, and consider that it isn't how you might see it or how it's portrayed. It can be much more than that. Thank you.
Thank you, Adrian. Jenny, and then on to Liz.
Hello, yes, I think the thing that I really want people to know is that obviously our team exists here in hospital, and obviously we're here to help. So I just want people to know that our service is available. If you have a loved one in hospital, ask about our team, see if we can get involved. And if you're a staff member as well, to call us if you'd like some support and supporting someone living with dementia. And I also can't say how important the This Is Me booklets are in supporting people living with dementia here in hospital. So if you know someone living with dementia, do one, they're so helpful. And if you're working in the hospital, then if you see one, please read it, because it will really help you support the person while they're here in hospital.
Thank you, Jenny. And Liz.
Hello, Jenny has stolen my point. So without trying to repeat it, you never know when you're going to need to come into hospital. We are here to care for you. There are services here. There are services out in the community. Just ask. If you ask one of us or one of the services, we'll link you in with everybody else. Knowing as much as we can about the person will help us all to care for you the best way we can. Don't be shy in coming forward and telling us what you need to know. Complete This Is Me, we'll share it with the people who need to see it, and if we know that information, we can care the best way we can. Thank you.
Thank you very much. And that leaves me, and I can't say enough that the success of this session today is really down to not just the panel, and I will come back to the panel, but everybody's really insightful questions, because that has meant we have hopefully helped you. And I can see some of the comments have come up that people have really enjoyed this session. If we haven't got to your question, you can always contact any of us here. We do intend to put the shortened versions of the slides that Liz presented for our strategy on our website, and that's one of the earlier questions. And we are always happy to talk about how we can improve our dementia services. And there are some great resources that people have posted in the chat box, so if they are useful to you, do dive in and explore those. And I'd just like to say a really massive thank you to all of the panel today who have really shared their expert advice and guidance, and also I think demonstrated a commitment to delivering excellence in dementia care, not just at the Norfolk and Norwich, but across every service and indeed across our county. So please do make sure you come forward either as a carer or as a relative or somebody that wants to get involved as a volunteer for our dementia campaign. And this truly is a momentous, I think, a momentous occasion to launch the 5-year Norfolk and Norwich dementia strategy. So thank you all very much.